presenter is Dr. Arun Sharma. Dr. Sharma is a clinical professor in the Division of Prosthodontics at the University of California, San Francisco School of Dentistry. He is a diplomate of the American Board of Prosthodontics. Dr. Sharma also maintains a private practice and is the director of the graduate program of prosthodontics at UCSF. He serves as the prosthodontist for the Center for Craniofacial Anomalies and the Head and Neck Reconstruction Team. Dr. Sharma received his dental degree from the University of Bombay in 1983 and a master's in prosthetic dentistry from the University of London. He then completed a prosthodontic residency from UCSF and a maxillofacial prosthetic residency from UCLA. Dr. Sharma has contributed to 7 textbooks and authored many articles. He served as assistant editor of the Journal of Prosthetic Dentistry and is currently the chair of the editorial council of the JPD. Dr. Sharma is a past president of the Pacific Coast Society for Prosthodontics and an American Prosthodontic Society and president-elect of the American Academy of Maxillofacial Prosthetics. He's been the recipient of the Thomas Curtis Award for Excellence in Teaching from the prosthetic residents on 13 occasions. So please welcome Dr. Sharma.
Great, thanks, Dr. Yant. You guys can all hear me?
Yes.
Okay, perfect. Now I just got to share my screen and we'll get started. It's challenging times, as we've all heard, and my screen's up as well now, I hope, right? I see the screen. First slide. Can somebody verify that you guys can see the slide? I'm not hearing anybody.
Yes, we can see the slide.
Great, perfect. All right, we'll get started. So Dr. Yan, thanks again for this presentation. And Nakia and me were corresponding, I guess, over almost 2 years ago when they asked if I would be willing to come and speak to the San Mateo County Dental Society. And I think this is my second time that I'm doing this. The first time must have been over 10 or 15 years ago. I always look forward to meeting colleagues in the Bay Area and doing presentations in the evening. And like Dr. Yan said, you know, the idea is to be face-to-face with people. And I enjoy giving talks when I can sort of interact with the audience. That mode of interaction is going to be very different. And so my sort of style of lecturing is going to not be as great as I enjoy it to be, but we'll try and make the most of it. So what I'm going to share with you tonight is the experience that I've had almost for the last 25 years at UCSF, where we've treated patients, young patients who are not fully grown and who have the need for implants. And what is it about this group of patients that's different, and what are the things that you should be watching out for is what I'm going to try to convey. So with every presentation, I like to sort of outline an objective. And the objective of this presentation is going to be to present some guidelines for implant therapy in children. And the reason why I choose the word guidelines is because we just don't have a ton of evidence to tell us what we should do. And what is good for one patient may not be good for another patient. So not sort of a fan of having strict yes and no scenarios here, but present more guidelines that would help you establish what is appropriate to be done for a patient in consultation with the family. So it's sort of a joint decision that has to be made. When you talk about implant dentistry in young children, I mean, you'll hear some common statements that have been made or questions that people ask. And the most common statement that across is one that says implants should not be placed in children. And I guess if you want to be completely safe about it, that would be an appropriate statement to be made. The question that always people want to ask, though, is that if you're not going to place implants and you do want to place implants, at what age should you place implants? And this is going to be a very difficult question to answer in general. And I'm going to, hopefully by the end of this presentation, provide you enough guidelines that will help you establish what the age should be for a different type of patient and why it's important to sort of not have one age as a landmark. Because, when you think of age, most of us were taught about growth. How do you evaluate if somebody's finished growing? And it probably came to us from some of our classes in the orthodontic department, and it was the hand-wrist film, which was the classic example. The reality is that in this situation, when we're talking about replacing a missing tooth, the growth of the kid in height is not what we're looking at. We're really looking at as to what's going to happen with the teeth and the jaws. And so what happens with the hand wrist film may not be an appropriate guideline for. Now, why is this a problem to start with? Well, the reason why we're concerned about it is because it's really a well-established fact that implants behave like an ankylosed tooth. So if you place an implant in a site in the jaw, mandible or maxilla, doesn't matter, and the adjacent teeth continue to erupt or continue to grow, you're going to have a problem. Very similar to what would happen when a tooth is ankylosed. You can have, if it is an anterior tooth that's ankylosed and the adjacent tooth erupts, you're going to have an incised edge discrepancy. You're going to have a discrepancy in the free gingival margins of those tooth. So the problem is exactly the same as what you would see with an ankylosed tooth in a young patient. And so this is an example patient that I treated early on. This patient was treated in 1991. And you can see, this kid was 5 years old when we put implants in his mouth. And we'll talk about that later as to why we did that. But in the lower jaw, he's had some implants, and you can see there's a bar. And like most kids, oral hygiene is not his strong point. But when you look in the maxillary arch, you can see where the implant bars are and where the teeth are. And you're going to have to take my word for it that when these restorations of this bar was made, it was not a discrepancy between where the teeth are. So what's happened? The implant bar, or the implant which was ankylosed, stayed where it is. These teeth continue to erupt, and you're starting to see this significant discrepancy. I always start off with this slide because it's a dramatic discrepancy that is visible into what's happening with the implants and how we've learned from this process, and what we wouldn't do in future, or the guidelines that I will be giving to you today are based on some of these experiences that we've had. Now, another example that you see here is another young kid that I treated with a congenitally missing lateral incisor, and you can see about 5 years after the treatment, and I'll show you this patient later on again as well, you can see what's happened. The implant restoration has stayed where it is. The adjacent teeth have erupted, so we've got an incisal edge discrepancy and a free marginal discrepancy. So this is the problem we're talking about, right? This implant, or these implants, are like ankle, whereas the adjacent teeth are going to move if the growth is not completed. And that's the concern that we have when we talk about putting implants in young people. So are all patients the same? Well, not really so. And so the question about as to what age you should put an implant in cannot just be answered that easily, because I'm going to use this example of a patient congenitally missing a lateral incisor. Orthodontic treatment is almost completed. It is completed in this slide. As you can see, the appliances are off place. But is this patient the same as a patient who is partially edentulous, who's missing all the teeth in the mandible and has some teeth in the maxilla, versus a patient who's completely edentulous? So if we were to get an answer and say what age, just let's use the word number 18, for example. Well, 18 is not necessarily appropriate for this kid, because this kid could have implants placed a lot earlier. And the reason being primarily that there's no teeth. So if there's no teeth and the teeth adjacent to the implant's not going to change or move, you could place your implant earlier, provided you've taken other considerations into place as well. So the point that I want to make for you is that we've got three different categories of patients. We've got a patient who's congenitally missing just one tooth. We've got a patient who's partially edentulous, like you see in here. They're missing some, and you got a patient who's almost completely edentulous. I know there's one tooth in here, but for all purposes, that tooth is pretty much not going to be of any use for us in the long run. So basically, these three patients are three different patients. And if they were all to have the same criteria of age 18, I would beg to say that it is not appropriate that each of these three patients receive implants at the same age. There's different criteria that we need to be looking at to establish when they should receive the implants. Okay, so we're going to share for the next few minutes a couple of studies that I was involved with at UCSF, which helped sort of establish the guidelines that we have presented in a couple of articles in the last few years. So when I first arrived at UCSF after finishing my residency program at UCLA on faculty, I was asked to be facial center. So I went up to the cleft palate clinic, and really my training and my pros training didn't have a lot of cleft lip and palate experience at UCLA. And so I was sort of learning as we go. And I was more an observer than I was an active sort of provider, so to say. And the chair of the oral surgery department at that time, at that stage, was a guy by the name of Dr. Caban, Len Caban. And he was very well known in the world of pediatric surgery or pediatric oral maxillofacial surgery. And he was chatting with me and says, Arun, let's start doing some implants. And I looked at him like, we're going to put implants in these kids with clefts. And he was like, yeah, nobody is doing it. And so maybe we can do a couple of studies. So the first study we got involved with was putting implants in alveolar clefts. And I'm going to show you how the study came about and share with you some of the outcomes. So, a typical example of a cleft lip, this is obviously a baby when they're born, but as they've developed and aged along the way, you can see that this particular site in the CT scan is where the alveolar cleft is, and there is no bone in this site whatsoever. So our goal would have been to place an implant in air, right? But obviously create bone before that, because the options otherwise to replace the missing tooth were pretty limited. When we talk about a missing lateral incisor, we can either have a fixed option, a removal option, or an implant option, right? Standard prosthodontic management doesn't matter what the cause of the missing tooth is. Our choices are pretty much fixed, removable, or an implant. But when you look at a young kid, they're only like 16, 18 years old and they're missing a lateral incisor. Most of them are not probably going to be too happy if they have to wear a removal appliance for the rest of their lives. And, taking two perfectly good teeth and cutting them down to do a fixed partial denture is not something most of us would like to do to a young person, knowing that life expectancy of fixed partial dentures 5 years is probably less than 50%. And so why would you take two perfectly good teeth and cut them down? And so an implant, like in all scenarios in this group of patients, is a very appealing option to avoid having to do something that's more dramatic. So obviously an implant, this is 1991. So implant dentistry was just sort of in the early days of implant dentistry, not like it is today. And so we had to sort of establish a protocol. And the study aims, as you can see here, the first study, can implants be successfully placed in grafted alveolar clefts? Is it necessary to regraft the cleft prior to implant placement? Can the implants be successfully restored and loaded? Those are the goals, but we also wanted to sort of develop a timing in terms of when should that cleft that I showed you be grafted and when should the implant be placed? Because we know if there's a large gap or an time interval between when the graft is placed and the implant is placed, the graft is probably going to resorb, and you may not have adequate bone to place an implant in, and you'd probably have to regraft it. So we wanted to sort of see if we could play around with the timing and minimize the morbidity of multiple surgeries for these children, which they already have to go through. So I'm just going to skip to some of the results now so I don't bore you late in the evening. And the current report, the last time we reported this was in 2006. It was a 13-year follow-up at that point in time. We had 33 implants that had been restored and 28 were still in function. So when we say 33 placed and 31 restored, that means 2 failed to integrate. So we had 2 loss at second stage, and then over time, 3 of them failed, and we'll talk about what happened to these in a bit. And we published the first study in 1997 in the Cleft Palate Journal. Of these implants, there were 24 patients, and 9 had bilateral clefts and 15 had unilateral clefts. The average age of when the alveolar cleft bone was 14.3. And this number was a little skewed. We normally do this alveolar cleft graft just before the canine is about to erupt in the patient's mouth. So, the canine is going to erupt anywhere between 11 and 13, depending on the development of the child. And the reason why this number got skewed is because we had one older patient who was a recent immigrant that got included in the study. It was 26. And once we included a patient in the study, we couldn't really throw him out of the study because that one patient was part of the study, and you can't throw people out for your convenience later on. But the median age of grafting was 15 and median implant placement was 19. And this is an important number that you're going to want to look at later on as well. So as I said, 33 placed, 2 implants failed at second stage, 2 failed in a bilateral cleft patient after 4 years, and 1 implant failed in a unilateral cleft after 11 years. And I will talk about why I think this one failed after 11 years. It probably had nothing to do with a cleft, but the type of implant that we had selected for the first group of patients as part of our study, based on the fact that it was 1991, 92, and the type of implants that were available at that stage. So in follow-up time, more than 10 years since the restorations have been placed. And based on that, to summarize the outcome, we found that the dental implants were successfully placed in grafted alveolar cleft 93.9% of the time, and the restoration that could be loaded was 90.3%, because we did lose those implants, 3 of them after second stage. I will tell you anecdotally, though, that since 2006 to today, we have lost a few more implants in these patients. It's just not part of a study, so I can't sort of report it to you by numbers per se. All right, so example of a patient, alveolar cleft has been grafted. You can see there's adequate bone. The surgeon is creating an osteotomy to be able to place the implant. The implant is placed and the restoration is made. Almost everything that I like to do with implants is screw retained. And even back then, this was a screw retained restoration direct to fixture. And this is a radiograph. Now, for those of you who've been around as long as I have and been doing implants, you probably have no problem recognizing what type of implant this is. Some of you who've been in the field for less than 20 years probably would have no idea what this type of implant is. So I'm going to give you a little brief history. In the early days of implant dentistry, implants were 2 types. There was a sort of Brånemark implant that was a threaded or screw-shaped implant. And when you placed that implant, your primary stability was accomplished by the threads of the implant. The other implants that were out there, primarily by Z, and Calcitech also made a similar implant, had what was called a press fit implant. And what you see here is a press fit implant. And in this particular scenario, the primary stability of the implant was achieved by the size of the osteotomy hole being slightly smaller in diameter than the size of the implant. And once the osteotomy was created, the surgeon basically tapped the implant into it. So basically, you were taking an implant that was bigger than the hole and you hammered it in. And that's what gave it primary stability. Now, the IMZ surface of implant was plasma sprayed, and then the Calcitech surface. Plasma sprayed and HA coated implants that were press fit failed over time, because once you ended up getting bone loss, the roughened surfaces were exposed, and that created a cascade with loss of failure. So even traditionally, the IMZ implant disappeared, and they're not even on the market. Now, why did we choose this implant in the first place? Well, in those days, obviously it was early on. There was not too many studies available to talk about the different implants. But what was study, and that study was done out of UCLA, actually, in sheep, that when they placed implants that were threaded versus press fit versus HA coated, and they did second stage surgery and they looked at it histomorphometrically, they were looking at how much bone implant interface there was. And what they actually found was that at second stage, or about 6 months after an implant's been placed in bone, if you looked at the traditional Brånemark threaded implant and you looked at the bone implant interface, there was only about 56% of bone in contact with the bone, with the implant. The rest was just air. However, fit implant like you see here, right, the surface bone implant interface was about 65%. And if you had an HA coated implant, it was almost 72%. So the theory was that if you have better bone implant interface, then when you have softer bone or bone that is not so dense, like in the maxilla or in this completely grafted bone, you may want to consider a non-threaded implant. And so that was the basis as to why we selected these implants for this group of patients. Obviously, halfway through the study, the report started coming we sort of switched to using threaded implants. All right, so another example of the implant here. And this is actually the patient in which this implant failed after 11 years, and it was a press fit implant. So I don't believe that this implant failed because this guy was a cleft kid. It just failed because of the type of implant that we had selected for this patient. This is an example of a bilateral cleft patient where we had 3 implants. We actually had a 4th one that failed at 2nd stage. And this was his fixed partial denture. And he actually sent me this photograph when he got married. If you remember the very first slide that I showed you in the cleft kid, there was a patient with a yellow like t-shirt kind of thing with a baby. That was actually this kid. So when you're doing this cleft work, sometimes you've been around to see these kids from babies to as they grew up. And it's kind of satisfying from a standpoint. This is another patient with restoration done in his mouth. So when you start looking at these cleft kids in general, you're going to always have soft tissue challenges because when you remember this entire area used to be air, and this has all been surgically closed and grafted to create both soft and hard tissue to have closure. And then we're putting an implant into that and wanting it to integrate. And so you can see this is one of the later patients in the study that then ended up with a threaded implant when we stopped using the plasma spray. Example of a threaded implant that was placed. And again, this sort of soft tissue deficiency that you see. But when we followed these patients over time, we started to see, incisal edge, marginal ridge, things that were going on that helped us sort of develop the guidelines. So based on that, we sort of came up with this first guideline for you that when you have a partially dentate growing patient, you have to be very careful when you plan to place an implant early on. So this is the kid that I showed you among the early scenarios when we were talking about ankylosed teeth. This implant was restoration was placed on this young man when he was 16 years and 8 months by me. This is actually on the day that I'm trying in the restoration. You can see the tissue is still blanching. But what I want you to note is the relationship between the pregingival margin between the central and the lateral and the incisal edge position between these 2 teeth. The kid disappears, comes back 5 years later, and he's 21 years and 4 months of age, and you can see what's happened. We placed this implant before his growth was completed. Now, what type of growth am I talking about? Because we asked this kid, hand wrist film, has he grown any taller? Has he changed his shoe size? All were in the negative. Nothing had happened for him for a while. So it's not the growth that we're concerned. The director of the craniofacial clinic, and she's retired now, by the name of Karin Margovic, and she actually has coined the term that what growth we're talking about here is not general growth, but dentoalveolar development. So when does dentoalveolar development come to a stop? Or when does it sort of get to a point when there's going to be minimal change? That is going to determine when you should place an implant if you've got teeth next to it. Now remember the word dentoalveolar, because that's really important, because that's what I'm saying to you in the other 3 examples of partially edentulous or edentulous patients where there's no teeth, there's no dentition, the dentoalveolar growth is going to be very different. So what concerns we have with implants adjacent to teeth may not apply to scenarios when we're placing implants where there's no teeth adjacent to that edentulous spot. Right? So keep that in mind here as we go along. So what did I do for this kid? Well, I had to remake the restoration, right? I did it at no cost to the kid because it was, I felt bad that I was part of the process of placing this restoration on this kid. And, I had to make a custom abutment because the other thing that happened here was not only is there dentoalveolar change that occurs vertically, but there's also a horizontal. So if I was to go back 1 slide here, you can start to see that this tooth, as it's erupted, is also sort of got a little bit retroclined. Or if I didn't have a good occlusal view of this, but if you were to look at this, the lateral incisor is sort of out of the arch facially compared to when it was first placed, right? So that made it challenging for us to make a restoration. I had to do a cement on, and so I had to make a custom abutment and a cement on, lithium disilicate type of restoration. And I was able to correct the incisal edge discrepancy. And in him, the marginal discrepancy was not too bad. Obviously, this is not ideal. We all know that the free gingival margin or lateral incisor needs to be more incisal or the canine, and that's not the case. Now, fortunately for him, the smile line is not so high, so that gingival display does not occur. But gingival display occurred when he smiled, practitioner, you may not be too happy with that outcome of the discrepancy across the front here. And there's nothing you're going to be able to do to fix that because that implant is where it's placed and you're stuck with it. So how do we determine then that dentoalveolar development is completed before we're ready to? One way to do it, and that is to have lateral cephs. And you have to have a lateral ceph a minimum of 12 months apart. And you need to overlay these lateral cephs, and you need to make sure that no changes occurred in the position of those teeth. So if you look in this particular example, 2 lateral cephs a year apart, and you can see there's been change, right? These two things are not lining up. So in this particular patient, we're not ready to place an implant in this kid because there is still ongoing dentoalveolar development, and that would lead to a potential problem like the one that I've just shown you. All right. So with that in then we start to sort of get a better idea to be able to answer the question of age, right? So the answer to most patients is I can't give you a number because I don't know when your dentoalveolar development is going to be completed. I need to have a lateral ceph a year apart. That could be 16, could be 18, could be 20, could be 21. We don't know that answer. We have to have lateral cephs available. So let's look at this patient. This is the example that I shared with you earlier. Lateral incisor, restored, beautiful outcome in terms of the gingival relationships. Another patient, congenitally missing lateral incisor, restored, good outcome. So what's the commonality between these two patients? Well, the commonality is that this is brother and sister. The first image that I showed you is the sister. Second image that I showed you is the brother. They're both congenitally missing their lateral incisors. Now, for the brother, we had 2 lateral cephs at age 18 years and 6 months of age that showed no change, and therefore we placed the implant. The sister, it was 16 years and 2 months of age. So there's a difference, male versus female. If in anything, in general, in females, you're more likely to have 2 lateral cephs with no dentoalveolar change earlier than you are with males. But I want you to follow with me what happened to this male down the road as well, because there's lots of reports in the literature that talk about ongoing change in the dental and oral cavity. And the question is, which patients is it going to happen in and how much? And we don't know the answer to that just yet. I'm trying to get some of our residents to do a study on that aspect. But this is the male now, the brother. The image to your top left, 19 years age in 2004. That's kind of when the restoration was delivered. You can look at the relationship, free gingival margin, incisal edge. In 2011, look at the incisal edge. 2016, he's now 31 years old, all right? There's been a change. Teeth have moved. Gap has opened up. Are we going to be able to manage this in every patient? Now, I'm going to say to you no, because to me, this is one of the biggest problems that we have with single tooth implants in the anterior part of the mouth. There are some patients, like you see here, I had 2 lateral cephs a year apart that showed no change. But from age 19 to 31, there has been change, subtle change, but enough where you can see a discrepancy because now there's a diastema, there's a change in the length. If you compare the relationship of the gingival margin lateral to canine central, there's been a lateral to canine doesn't look so bad, but that's because he's had some recession on the canine, right? Look at what's happened to the gingiva here versus the gingiva on the canine. So this tissue is receded, and therefore this relationship doesn't look so bad, but the central didn't get recession. And you can see from this image to here, there's been a big change. So dentoalveolar development is going to keep on happening. I see there's a couple of questions in here. Kenny Moore. You want to know, given some of the studies, success rates were affected by the type of implant placed. Have they been replicated studies with more than implants? I'm going to answer this later for you, Ken, when we come down to it. And William Bohannon, what if you have a lab where the Ceph machines change frequently and have it? Yeah, so you shouldn't have Cephs that change. The machine should be the same. I mean, if the machines are changing, then the Ceph is really not active, not effective. So, that is taken for granted. In most centers that are following growth, the lateral Ceph machine is going to be the same and the patient has in. I'm sorry, I took those questions. I think you wanted me to answer them in the end, but I feel it's easier to answer some of these questions as we go, as if I was in a real live conversation with you folks. I hope you don't mind my interfering with that. So if a patient comes in and they are congenitally missing a tooth and we don't have the lateral Cephs, my recommendation is to do some sort of interim restoration. And I like to do Maryland bridges if I can, because one of the challenges is when I'm going to go back a couple of slides, when you look at the radiograph here, and when the orthodontist has spent a lot of effort in creating this space for you by uprighting this tooth, and if you're waiting for this implant and you just have like a flimsy retainer going in and out of the mouth, root is going to tip back. So I think it's really important to have something rigid in here that's not going to allow the root to tip back. So I use Maryland bridges to help sort of keep that in position. And therefore, people will say, oh, if you do a Maryland bridge, lots of studies that say a unilateral Maryland bridge. Yeah, unilateral Maryland bridges work fine. But remember, my goal here is I'm trying to prevent this teeth from moving. So I want a rigid relationship on both teeth. Okay. So we're going to go to the next study then. And this study happened to be at the same time as the first study, because when I was standing there talking with Dr. Cabin, one of our plans was to place implants in alveolar clefts. And the second group of patients that we had was patients with ectodermal dysplasia. Now, not too many people around the world see lots of patients with ectodermal dysplasia, but San Francisco or the Northern California has large families with ectodermal dysplasia because, as you know, most of ectodermal dysplasia is genetic. It's X-linked. And so when it's in the family, one of the biggest problems with ectodermal dysplasia is that these patients don't tolerate heat very well, right? They don't sweat. They don't have the sweat glands. Bakersfield, where it's hot as hell. They're going to move to Northern California, where it's fog all the time and it's cold and they can survive better. So these families have just intentionally moved to areas that are cooler and colder. And so there's a large population. And we have an ectodermal dysplasia clinic at UCSF 4 times a year, where on those 4 Mondays in the craniofacial clinic, all we see is kids with ectodermal dysplasia. So we had a large patient population that we could utilize for this study. And obviously, these patients could also benefit significantly with having dental implants, because there's a wide gamut of patients with ectodermal dysplasia. It could be missing teeth, like you see in this particular radiograph. And so, what is the problem? Well, from a prosthodontic standpoint, normally shaped, the disc is easy. The ridge has basically, there is no ridge, right? And because there's no ridge, there's going to be no retention or stability. I've put a question in progressive bone loss because people say you make a denture and you're going to get bone loss. Well, there's nothing to be lost. There was no ridge to start with. I'm a believer that the dental alveolus, the alveolar component, only develops with teeth. And so where there's no teeth, there's no ridge. There's no height, there's no width. It's just basal bone, right? And so where is this going to resorb? It's not going to resorb. It's going to pretty much stay the way it is. So I don't believe that progressive bone loss is an issue. And then there's a question of remaking the prostheses. And yes, that's a challenge. But again, you only have to remake the prostheses if there's teeth erupting, because only if teeth erupt will the shape and the form of that ridge change. If there's no teeth, this ridge is not going to change. So the fit of the denture is really not going to be impacted. But you can see treating patients like this with traditional dentures would not, most prosthodontists would be happy to do, right? And so those were obviously challenging scenarios. Now, I have changed my tune a little bit. Part of the reason why I became a prosthodontist was because I didn't want to treat kids. Pediatric dentistry was not one of my favorite rotations. And here I am dealing with young kids. And, today I make dentures for kids as early as 4 years old. And the reason why I believe that making dentures for the kids is important is, one, it allows them to use to having some sort of prosthesis in their mouth, because in our study, which I'll share with you in a minute here as we go along, the 7 patients, some of the patients that we treated with implants later on had never worn a prosthesis before, found it extremely challenging to accept prostheses in their mouth. And so making prostheses early allows them to sort of work through those difficulties and therefore be able to wear a denture better later on. And then the first time I actually made a denture for a 4-year-old, it was a patient whose mom was a nurse. And she insisted that her 4-year-old kid, for psychological reasons, get teeth before this kid goes back to or starts out going to school. And so I was like, are you crazy? Dentures can't work, and that was more my sort of hesitation, not wanting to work on a 4-year-old. But she sort of twisted my arm and made me make the dentures for this kid. And this kid wore them successfully, amazingly. So now I routinely make dentures for kids. And the cutoff is as early as they can sit in my chair and as early as the kids want teeth, right? So the youngest has been 3.5 that I made teeth for. So what am I looking to do in these kids, right? So if they come presenting with a panorex like this, I want the orthodontist to bring those two together. I'm going to bond them with composite to make them look like normal teeth, right? Like you see here. And I'm going to make them an upper partial and a lower denture. And this is going to let them have a vertical dimension, because without teeth, they all tend to be overclosed. So this allows me to establish what the vertical relationship is, gives them teeth, and I will be surprised. I'm telling you, if you don't believe me, you got to make these dentures for these kids, and you'll be surprised as to how well most of them tolerate them and use them in a really good way. And then this is really a good guideline for us when we are doing implants, where to put the implants and what type of restoration are we going to make, what's the occlusal plane, how much space do we have. These are all things that are going to benefit us in the long run anyway. So this is a young 3.5-year-old kid who fools around in the clinic every time he comes to see me, and I asked him if I could take a picture, and right when I was about to take the picture, he stuck his tongue out at me and thought it was really funny. So I will make dentures for them early on, as I said. I'll make both the upper and lower together, and I only delivered the uppers first. I let them get used to the upper for a few weeks or a month, and then I give them the lower. I think trying to give them both upper and lower prostheses at the same time is just too much for them to adapt to, right? To start out slow, give them the one that they give them the second one, and then they're going to wear it comfortably. So treating kids, ectodermal dysplasia, you got to make dentures for them early on, as early as the kid wants them. Because if the kid doesn't want them, they're not going to wear them. So the kid has to say, I want teeth, or, why do I not have teeth, or something like that. If the parents are just pushing for it, it's not going to work. The kid's going to have to say, I want teeth. All right. Obviously, we know what the advantage of implants are. They're going to help us with stability retention. And if you can get good, stable, retentive prosthesis, it's going to provide improved function. And we have the possibility of giving them some sort of fixed restoration if everything else lines up the way we would want it to. What are the potential problems with implants in this particular group of patients? We want to know if there's an effect and the growth continues, what's going to happen to the implant? That's kind of like the ankylosed tooth scenario that we talked about in the previous discussion with cleft kids. In this group of patients, we wanted to know if we put an implant in early and we make a restoration, full arch restoration, is that implant restoration going to somehow impact the normal growth? So is it going to impede? Is it going to interfere with? Is something like that going to happen? So that's a question we had to have answered. And we wanted to sort of know what the long-term success rate is. So again, these studies to get IRB approval is very challenging. Whenever you have a population of children and you're trying to have them in a clinical trial of some sort, the IRB is very, very strict, because you've got to be absolute why the procedure is going to be beneficial and why and how what you're going to do is going to be completely safe for the child, right? So IRBs are very, very strict. And so we had a tough time getting IRBs, but we were able to prove our case and have approval for both of these studies. So the aim of the study: can implants be successfully placed in patients with ED? Can implants be successfully restored and loaded? What is the effect of normal growth on implants, and do implants interfere with normal growth? Right? So let's see, another couple of questions popped up here. Sarah Andrews, since ankylosed primary teeth act as implants, do you recommend routine extraction in case of a congenitally missing permanent tooth in order to allow for dentoalveolar development and prepare. Yeah. So let's answer this question later, right? So let's hang on to that. That's a good question. Okay. So our study population, 1991, we had 7 patients. Now, one of the challenges that we found when we started with the ectodermal, with the cleft palate patients was, our goal was to have like 50 patients or 50 implants. And we only got to like 33, as you saw. And it took a long time because recruiting patients to all have them lined up at the right time to do a study is very challenging. And especially if you want to get all the patients starting on day 1 and finish on day whatever the end point of your study is. So for the ectodermal dysplasia, we actually called it a pilot. And we said we were only going to enroll 7 patients because we wanted to start at day 1. We wanted to follow them for 5 years and be able to have our results for all 7 patients from start to finish in 5 years. So 7 patients, as you can see here, implant placement, age range from 5 to 14, place restoration 6 to 15. Now you'll see this one patient was 5 years old when the implants was placed, and we enrolled him in the study with a lot of difficulty because partly he was taken into the study because the parents insisted, because he had an older, was 8 or 9. I can't forget what the age difference was. But the parents said if one kid's going to get teeth, the other kid's going to have teeth. So they wanted both kids to be enrolled in the study. And for us, initially at 5, we were really concerned that that was too young. And we went back and forth, and we had to go back to IRB, and we finally agreed to treat the 5-year-old with the implants as well. So this is one of the examples of these kids with ectodermal dysplasia, Enrique, and you can see his teeth here that remain. We brought the 2 teeth, the 2 adults' teeth that were, peg shaped, whatever you want to call them, orthodontic treatment, bring them together. We've taken the 2 primary teeth, which have pretty good roots. We're not going to remove them. We're going to do endos, and I'm going to use them as overdenture abutments. We're going to place 4 implants in the maxilla in this study. Now, if I was to do this again, you can see the results here of how the implants were placed. Again, you'll note all of these implants were plasma sprayed implants, again, for the reason that I pointed out to you early on. Now, if I was to do this study today, or if treating patients today, I would not place implants in the maxilla because I don't think these implants in any way contributed significantly to this patient having an improved prosthesis. When there's that many teeth in a palate, a partial would just work fine. And you would see the complication of these implants being too high up in some of the scenarios, and we want to avoid that. So we would not do implants in the upper arch today based on the study. I would do definitely the lower arch, as you'll see in a minute. So that was his restoration. He was about 13 years old, I think, at that time. Crowned those teeth, overdentured, bar, restoration. One of the implants that failed was in this kid. There were 2 placed up here, if you remember the previous Panorex, the bar going across, and the restoration that was finally put in his mouth, and then a follow-up over time. This is an example of a patient who was completely edentulous, and we had this one tooth. We took this tooth out. It was really going to be hopeless and no purpose. We put implants in there, and you can see these implants were actually not splintered across the midline. There's a little gap, and this is where we were measuring to see what transverse growth, if any, was going to occur. And the idea being that if growth was going to occur in the maxilla or the mandible over time, then that gap that we have would increase, or the gap would get bigger. So we want to be able to measure that, because if this was splintered across the front, maybe you could say we were interfering with the growth. So we wanted to see whether there was any growth. Our hypothesis was there was going to be no growth of the dental-alveolar complex because there was no teeth. The maxilla grows down and forward as the teeth erupt. If the teeth don't erupt, that part of the maxilla is not going to grow. So we didn't think it was going to be a problem, but we had to measure that to show it to people. Right? Published in a paper. Results for the maxilla: 22 implants placed, 21 were restored, 1 failed at 2nd stage. 20 of those were still in function when we re-looked at this group in 2005. 1 was lost in 1998. All six patients had removed prosthesis. In the mandible, we had 24 implants placed. All 24 were restored, 100% integration, 6 removable, and 1 fixed prosthesis. Time from follow-up in the placement, as you can see here, in time since restoration. An example of another patient who had just primary teeth, implants placed, lateral ceph, restoration on the day or soon, and his smiling face. Now, when we follow this patient, you're going to start to see what's going on with the growth. So remember, we said dentoalveolar development, right? No teeth, so no dentoalveolar development. So there's going to be no vertical change in any relationship that we're talking about because there's no teeth erupting up and down. But the mandible is still going to continue to grow. And the growth center for the mandible is going to be what? The condyle. So the mandible growth center is the condyle, mandible is going to come down and forward, right? So when you follow this patient, that's what's happening. His mandible is growing, it's coming forward, there's an interference, so he's knocking off the teeth on the hybrid prostheses and breaking them, right? And you can see he's growing, he's even got a little bit of a goatee now. But if you look at the lateral cephs from 93 to 95 to 96, you can see how much the mandible has grown going forward. And you can see the change that's happened. The implants, it's important to realize is the implants are in the mandible, they've grown with the mandible. As the mandibles come forward, the implants have grown, right? That shouldn't be changing. They're sitting in the mandible in a different position. So he got to a point when he was significantly class 3 and the decision was made that he would need orthognathic surgery to correct two-jaw surgery. His insurance changed and he was going to have the jaw surgery at Kaiser. And I don't know how many people know, but there's a really good oral surgeon at Kaiser in Oakland by the name of Felice Ryan. And I worked with her for close to 30 years. And she called me up on the day she did the surgery for Mark and goes, Arun, I go, what happened, Felice? I was like, there's some disaster. And she was like, no, this was the easiest two-jaw surgery that I've ever done on an edentulous patient. And I was like, what are you talking about? So, doing jaw surgery on patients who are edentulous is really challenging because the surgeons don't have any teeth to help line up where the jaws need to go. But if you remember, his mandibular prosthesis and his upper denture that I'd made for him on day of delivery was a class 1 occlusal relationship. And then it grew and the mandible came forward. So all she had to do was in repositioning is take my prostheses, fixed restoration in the mandible, overdenture in the maxilla, put them back in a class 1 occlusal relationship and plate the mandible and plate the maxilla, and she was done, right? And so she was very happy with the idea that the jaw surgery was much more predictable and manageable than she had imagined. Now, I obviously remade the prostheses for this kid after all of this, and you can see this is the final restoration. What I want to point out to you, though, is that let's just say if this kid didn't have implants placed when he was 11 years old, okay? He's about 20 now, 21, I think. He would have struggled all along with removable prosthesis. And then we would have done jaw surgery to correct the, and we would have placed implants in the jaw at that stage now, right? These white dots or circles that I made are the screw access holes for where the implants were. So if I was to make a hybrid type of prosthesis, if that was the plan for this particular edentulous patient, I would probably want the implants in this position. So what I'm trying to show you is that though these implants were placed almost 10 years before and his mandible grew like crazy and he had orthognathic surgery to correct them, these implants were still in an appropriate to allow me to make the restoration that is appropriate for him at this stage without any compromise whatsoever. All right? So based on this group of patients, we figured out that implants can be placed in patients with ectodermal dysplasia. Implants can be successfully restored and loaded in patients with ectodermal dysplasia. Growth does not alter the implant position because, as I said, in the mandible is growing, the implant's growing with it, the position is the same. And implants do not interfere with growth because those gaps that I showed you never changed when we followed them over a period of time. So again, in this group of patients, we've got two categories. We've got the partially dentate, like you see here, right? Some teeth. In this group, we want to be approached with caution, okay? Because if you place an implant restoration too early and those posterior teeth continue to erupt, you're going to end up with an anterior open bite. So this is an example of a patient that was treated not by our clinic, but by a colleague of mine, past resident of the UC Pros program, a few years ahead of me, who worked in San Diego. And he knew we were doing this study. And he had emailed me and Dr. Vargovic saying he had a patient with this scenario and would it be okay to place implants? And we said, yeah, he's edentulous, why not? So he placed implants and he made the restoration. And you can see these are all acrylic restorations. look like. But what happened in this kid? Obviously, he did not make these restorations with an anterior open bite, right? When he made these restorations, they were in occlusion, they were closed, the occlusal plane was correct. But as this kid continued to grow, these posterior teeth continued to erupt. And as the posterior teeth continued to erupt, the anterior teeth had an anterior open bite. So this is the challenge. When you have teeth, this is the kind of relationship that you have to be concerned about. Now, what would I say to a patient with a similar setup, right? If a young kid showed up, age, let's say 10, and had molars, and these are primary molars. Interestingly, these primary molars never ankylosed, they continue to erupt as well. All right. Would you place implants early on? Well, I would give the scenario to the parents and let them decide. Because what would I tell them? I would tell them, yes, we can place implants. We can make a restoration. The back teeth are probably likely to erupt, so the front teeth won't touch anymore. And at some stage, we're going to have to remake the restoration. Are the implants in a good position? Yeah, the implants is where they are. They're not going to change. If you hadn't placed the implants, you would still have this anorexia. But where this alveolar ridge is, this ridge would not erupt, right? So I want that person who asked the question about an ankylosed tooth, should we remove it to not allow the development, to pay attention to this portion? Because if there's no tooth, that ridge is not going to develop either, right? So we're going to come back to your question again. I think it was Dr. Andrews who asked that question about when the ankylosed tooth should be removed or not. So if we had this kind of defect, what would we do if implants were not placed? Would we bone graft it? And how predictably would a surgeon be able to graft bone for me vertically to grow bone from this level to that point? I would say most of the time, not very predictable to gain that much height by graft for that wide a space. So basically, you would place implants in the same position the other way with teeth, incisal edge, and pink acrylic to restore them, because that's what I would do if implants had not been placed. So in my mind, this particular kid had the benefit of having an implant restoration for many years. And all that's going to happen now is that he's going to have a new restoration made with a better aesthetic component of the incisal edge position and maybe some pink porcelain. All right. So coming back to this kid, I would not place these implants because these implants are doing nothing for me, right? He's got 2 teeth. He's got teeth back here. I can make a decent partial overdenture. I would place implants in the mandible. There's no adjacent teeth. There's nothing to grow about. This mandible may grow out horizontally, as the jaw grows, but the benefit of having implants is significant. Now, this is a kid that was treated with the NIH study early on, and you can see his implants were placed early on, and he chose not to have jaw surgery. So that's going to be a problem, because if the kid chooses not to have jaw surgery, the implants in the mandible are way in the front. So his restoration is reversed. All the screw access holes are in the anterior part of the mouth, right? He chose not to have jaw surgery, didn't want to have 2 jaw surgery, right? You can see his maxilla is sort of retrognathic in a way, or whatever you want to call it. His midface has not developed. I've tried to make him upper teeth with this big flange and push it out to give him a class 1 relationship, but there's no way with these implants that were placed early on. Early, like 6, 7, 8 in that mandible, we've got to tell patients, right? You're going to most likely need jaw surgery. And if you don't get jaw surgery, your implants are going to be sort of in a reverse position provided. But it doesn't change whatever is happening with the position of the implants, because these implants are growing, as you can see, with the mandible coming forward. So when the original restoration was made, it was over here, but that's changed as time has gone on, right? And that was his maxillary prostheses. You can see where the implants are and how much of a class 3 relationship he is, and how thick this flange is to give him some type of lip support. But this kid didn't want to have jaw surgery. He's happy living with his prosthesis. So another kid that comes in, 2 teeth in the front, we bring him together, we put some composites, we place just 2 implants in the anterior mandible early on and give him an overdenture, right? This kid was 8 years old when we did this for him, so that you can see just some radiographs showing as part of the restorations. We splintered these crowns together because I didn't want these teeth to move apart. There's a tendency for teeth in this to move apart. So I'm going to splint teeth that don't need splitting for trauma, occlusal trauma reasons otherwise. Okay, and that's what his restoration looks like. So if you have a patient, we're coming to the last few slides here. I know 1 hour was my time, I believe, and I'm almost there. What are we going to do in a scenario like this, right? What are we going to do for this kid? Well, I'm going to do nothing in the maxillary arch. Am I going to consider placing implants in the mandible arch? Maybe, maybe not, because this scenario is exactly going to end up like if we put implants early on in the mandible, posterior teeth are going to erupt. We're going to have occlusal plane discrepancy. It's not going to change. So the parents are going to have to decide in this scenario. My role is to give them all the scenarios of what's going to happen if you place implants and if you didn't place implants. And so in an edentulous growing patient is much more predictable, right? So this patient, I'm much more likely to recommend patients getting implants early. In the mandible here, absolutely early on, big benefit to getting implants in this particular patient, right? I showed you all the examples of what works really well in this scenario. So implants for the growing child, again, edentulous growing patient, more predictable, consider placing early. Partially dentate growing patient, approach with caution. Obviously, if it's partially dentate and it's a single tooth, anterior aesthetics, you got to be even more cautious with your approach. That's where you're absolutely going to before you can plan placement of the implant. 3 case scenarios as to what you would do, right? 11 years, 9 months. Would you place implants in this patient early on? I didn't. You can see he's got some stay plates in his mouth. You could probably place 2 implants in the anterior mandible. That would help provide some support for that prosthesis and better function. Would I place implants in the maxilla? No, he would do just fine. Not really needed. Okay. Partially edentulous like this, I would not place any implants in this kid because all of the edentulous spaces where they're missing permanent teeth, they're going to be all like single tooth scenarios. So this kid needs to get orthodontics started early on, get all the teeth perfectly lined up, and then not take the teeth that there's no growth before you would place the implant. This is a patient who comes in at age 16 years and 7 months of age. Orthodontics is completed, right? They've got primary teeth that have been bonded and built up. Am I going to take them out and put implants in? Absolutely not, right? The patient's in no pain. There's minimal mobility. There's no symptoms. I don't have lateral cleft showing me that the growth is sort of stabilized, so to say. So just watch. You can't put implants in this kind of patient early on. So, you know, as being in a university setting, I get to write papers every now and then. And I write papers, and some papers I like to write, and some papers I don't like to write. In this particular paper that Dr. Wargovic and me published in the CDA, and now this goes back a long time. I even can't read when it is. Is there a reference in there? No, there isn't. But it's been a while since this paper was published. And when the CDA asked for us to write this paper, I was like, I don't have time for this. And, you know, of all the papers that I've actually ever written, this is the one that gets referenced the most. And all the papers that I was like more proud of writing probably don't. Everything that I've said to you today is kind of summarized in this paper in these 3 categories. So if somebody ever wants this paper, you can email me and I'll send you a PDF of it. With that, I'd like to thank you for your attention. Hopefully I didn't go over my time too much. And you have my email address here. You know, if you have questions for me, please feel free to email me. I usually answer my emails on a regular basis. So I see all the questions here. Is it okay if I just look at the chat and start talking about them?
Oh,
First
yes,
one is from,
absolutely.
Right. First one is from Kenneth Moore. Kenny, Dr. Moore says, given some of the studies' success rates were affected by the type of implant placed, have there been replicated studies with modern implants? I guess you're talking about the cleft patients. Well, even in that cleft study, only half the patients had the plasma sprayed. The other half were all threaded implants. And so since the case was really proven to be pretty effective with implants in that site, we would expect even better success with surfaces that are superior to what we have then. So I don't think there's any replicated studies that's being done with that in mind. Sarah Andrews, since ankylosed primary teeth act as implants, do you recommend routine extraction of an ankylosed primary tooth in the case of a congenitally missing permanent tooth in order to allow for dentoalveolar development in preparation for future placement? So yes and no is my answer to that. If the primary tooth is ankylosed and it's a single tooth, then I am more likely to consider recommending its extraction, because in that scenario, if you leave the ankylosed tooth, you're going to get a big defect between the adjacent teeth. Whereas if you took off that primary ankylosed tooth early on, and as the adjacent teeth erupt, you're going to space more than a few teeth, then I don't think it's going to change the scenario, right? So I wouldn't do it in that case. I would then maintain that tooth, because by maintaining the ankylosed tooth, we're also maintaining the width of the ridge. So if you took the tooth out too early, you run risking losing ridge width over time as well. So you've got to sort of compare these two ideas together. How big is the vertical defect going to be if I leave that tooth? And if I took it out, what is going to happen to the ridge width over time, the buccolingual width, if it's going to be many years before an implant is placed, right? So those are the two sort of balances. So I don't know if I answered your question to your liking, but email me if I can answer that more. Let's see. Jacqueline had a question. What criteria would you use when recommending extracting an ankylosed primary or permanent tooth? Question. Based on what kind of defect or deficiency you would expect in ridge and width, right? So if you think that keeping an ankylosed tooth, whether it's primary or permanent, is going to create a big ridge defect, and then you have to ask yourself, if you take it out, is the ridge defect going to be less of a problem for us to deal with later on? If that's the case, then yes, take it out. If you think it's not going to make a big change, then I would not take the tooth out. Meena Desai, if patient has upper maxillary bone missing on the right side, is it possible to have bone graft and implant for prosthetic? I'm not sure I get that question in terms. If the maxillary bone is completely missing, can they get a graft? Yeah, I mean, it depends on the size of the defect. So I don't know if I can answer this question, because I don't think the question is very clear to me. Dr. Moore, what is the age cutoff that you feel comfortable with, that you no longer need serial CEFs to confirm growth? I'm going to say for males, probably 21, and for females, 17. With females, I'm going to ask them the question of when they started their periods. And I think if you're 2 or 3 years after they reach puberty, then the growth is not going to be that significant. Okay. Chat. The chat. This is from Jacqueline. I have seen vertical changes in non-growing patients. It seems teeth are always going to adapt to occlusal forces over time. I think we should assume there will be. Absolutely right, Jacqueline. So one of the questions that I've been wanting to answer is, we know vertical changes occur in teeth, and if you look in the orthodontic literature, there's is Jacqueline an orthodontist or not? You can type that answer in for me.
She is.
Oh, she is. Okay. Yeah. So the orthodontic literature, I forget, I think it's what study is it? I can't remember the guy's name. It's a Swedish name with B, where they actually put these BBs in kids and followed them for 30 years with lateral CEFs, kind of study that would never be allowed anymore. And they showed vertical or changes in tooth position. Minimal. We're starting to see this problem with implants. And in that same study and others, they also state that, the orthodontists call it long face and short face. And they say the long face has more changes in tooth position over time than the short face. Now, in the pros literature, we look at long face and call it high FMA, and short face is where a person with short teeth, a lot of masticatory muscles, vertical, straight up and down, and therefore the teeth don't erupt. And FMA is bigger and open, muscles are not that up and down vertically, and teeth tend to erupt, right? My hypothesis is that teeth change more in the high FMA patients. And so that's the study I'm trying to get. My residents are working on it right now, to show that in patients with a high FMA, with implant restorations, that's where we see incisal edge position change more over time. And so that's the Bjork. Is it Bjork? All right, Bjork, I think was the name of that orthodontist. I know you typed Bjorn, but I think it's Bjork, the Bjork study. Yeah. So the question then is in high FMA patients, what would you do to limit that? We tell all our implant patients that they should wear an occlusal guard. And, so an occlusal guard acts sort of like a retainer and will help hold position better and minimize that change. So that's something we talk about. And if you talk to most prosthodontists and periodontists who have now been doing implants for a long period of time, they're all seeing change in position of teeth. And we only bring this up when it's an aesthetic issue, but I see that a lot. Even in the posterior part of the mouth, we know contacts open up, right, between teeth and implants, but that's mesial drift that occurs of teeth over time, and an implant is not going to drift. So changes are going to occur, but the vertical component is more aesthetically driven. Okay, so let's see. Dr. Polanski. Hi, Dr. Sharma. Thank you for excellent presentation. She's just one of my past residents saying she misses me. So Mina Desai, so patient is 50 plus years old, wearing upper removal partial with half maxilla missing and half prostheses. Are you talking about he's got an obturator of some sort, maybe? Did he have jaw surgery to remove that? That's going to be much more challenging. And yeah, that can be rebuilt too with a graft from his leg. He would need a fibula put in there. So that's major surgery, yes. All right, don't see any more questions.
All right. Thank you, Dr. Sharma. That was an excellent and informative presentation. I'm sure there'll be some more questions for you, so we'll get those to you and get them answered. So I want to thank everybody for joining us this evening, and have a great night.